Hello, my name is Sarah McKeeman and I am a physical therapist at Washington Hospital Center in Washington, D.C. I am the primary author of the article Physical Rehabilitation from Temporary to Durable Biventricular Support, a case report, that was recently published in the Cardiopulmonary Physical Therapy Journal. This article was written alongside with Robert Kupcho and Brittany Oakman, who are also physical therapists at Washington Hospital Center. For some background about this patient case, the article's conceptualization came to light when I encountered a 33-year-old female with severe biventricular failure due to chemotherapy-induced cardiomyopathy. This patient was transferred to our facility to be placed on temporary biventricular support via an Impella for her left ventricle and a Protect Duo for her right ventricle. Initially, the hope was that the patient was going to be able to be weaned from this temporary support. However, it eventually became clear that she wasn't. The patient also was not a candidate for a heart transplant due to her recent cancer history. The patient was hospitalized for 87 days and during this time had 2 Heartmate IIIs placed in order to make a durable BiVAD configuration. She had one placed in her left ventricle and one placed in her right atrium. This case report details the physical therapy interventions and interdisciplinary collaboration that we used to support the patient in prep for her multiple surgeries and thereafter to facilitate a discharge home. In terms of interventions, they were selected by the patient's goals, functional status, and identified deficits during each phase of her rehabilitation. The average treatment session was 38 minutes and included a variety of activities. This included functional mobility training, resistance training, including things like lateral banded walks, sit to stands, or step ups, aerobic training, including longer duration, moderate intensity ambulation, and higher intensity, shorter duration ambulation on a treadmill, and finally balance activities to promote her ability to perform her functional mobility while managing 2 sets of go gear. During the patient's ICU stay, sessions were performed with a nurse and a perfusionist present when she had a Protect Duo with an oxygenator attached. And all interventions were informed by vital sign parameters that were set by the medical team. Finally, we also had a nursing-led mobility program that had the patient ambulating out of the room on the days that she didn't have therapy once she had an AMPAC score of 24. Outcome measures were used to assess the patient's progress throughout her stay. We utilized the AMPAC, the ICU mobility scale, gait speed, the 6-minute walk test, and 5-time sit to stand. The patient showed meaningful progress on all of these measures and was progressing towards community cutoff scores and gait speed in the 6-minute walk test as she was approaching discharge. As a whole, physical therapy interventions for this patient were established by extrapolating current mechanical circulatory support literature and by using interdisciplinary collaboration. The interventions were feasible and maximized functional capacity for this patient, facilitating a discharge home.